Morning, everybody. I'm very excited this morning to introduce our speaker, Dr. Victoria Snegovskikh. She is the director of the UI Health Division of Reproductive Endocrinology and Infertility, or REI. She actually completed medical school and residency in OB/GYN in St. Petersburg, Russia, but then she relocated to the US, where she finished a postdoctoral fellowship and a second residency training in OB/GYN at Yale University. She's highly committed to women's care, education, and reproductive endocrinology research, and she enrolled as an REI fellow at Warren Alpert Medical School of Brown University, where she served as faculty for several years before relocation to Chicago. She practiced REI at the Reproductive Medicine Institute in Oak Brook, Illinois, before she joined us here at UIC, apparently just in January. So, welcome, Dr. Snegovskikh, and today she'll talk to us about oncofertility.
All right. Thank you very much for your kind introduction. As you already mentioned, I'm Victoria Snegovskikh. I'm happy to be here, happy to talk to you guys, and we're going to review fertility before and after cancer diagnosis, which is an important topic for everybody. So our objectives are going to be review of oncofertility and survivorship care. We'll discuss different treatment options for cancer patients, describe some key elements of egg versus embryo freezing cycles, and review some timing and further steps in oncofertility journey. So what is oncofertility? It's a subspecialty, as all of you know, and that combines oncology, which is cancer treatment, and reproductive endocrinology to maximize potential for cancer patients and survivors. And then we're trying to address fertility concerns arising from cancer treatment itself. It also refers to preservation of fertility for medical reasons, because not all of our patients are cancer survivors and cancer patients. We do have different other patients presenting to us to preserve their fertility. And if we look at this table, that's the most recent data from fertility preservation information from ASCO, American Society of Cancer Treatments, and they have not new, but quite old algorithm that was renewed in March of 2025 that gives us a couple of newer options. Like, for example, if you look at the bottom, for female patients, there are still some investigational methods like uterine transposition and in vitro maturation, which is getting eggs from not so stimulated IVF cycle and then maturing them in culture and then thawing them after and fertilizing them with the sperm later on. So this algorithm shows that, first of all, we need assessment of risk of infertility and communicate that to the patient. Then patient needs to be counseled by fertility specialist about fertility preservation methods. They discuss appropriateness of this care. And then at this point, usually the big question for the patient becomes, when do I get to use those eggs? When do I come back to you guys? Is it possible for me even to use those eggs that I freeze right now, or sperm, depending on gender of the patient? And what is the timing? And we work very closely with oncology team, and of course the prediction, the survival rates, and the type of cancer and stage of cancer are extremely important. For male patients, we have established methods like sperm cryopreservation or testicular sperm extraction, depending on their age and maturity. For female patients, we have embryo or oocyte cryopreservation, ovarian tissue cryopreservation, ovarian transposition, where the ovaries are moved away from the site of radiation, if radiation is the plan of cancer care, or conservative gynecologic surgery, when only part of the pelvic organs is removed. For example, in ovarian cancer, if only ovary is removed, the uterus stays in place, and so on and so forth. So in cervical cancer, only cervix is removed, which is trachelectomy, and then uterus stays in place, uterine body itself, and gives patient the potential to carry pregnancy in the future. For children and teens, some established methods are extremely important, and if they began puberty, it could be semen oocyte or ovarian tissue cryopreservation. For prepubertal girls, it's ovarian tissue cryopreservation, and we will get in a little bit more details after. Sorry, my slides are not advancing for some reason. Okay. Okay, so who are the candidates for fertility preservation for medical reasons? Not just cancer, but all medical reasons that we see patients for. Those are cancer patients who undergo chemotherapy that is gonadotoxic, patients who are going to be exposed to radiation of the pelvis, patients who will have oophorectomy or hysterectomy for any type of disease. Other gonadotoxic treatments, and we don't often think about them, are for autoimmune conditions like rheumatoid arthritis. Patients could get methotrexate, and methotrexate in high doses for prolonged exposure can also affect their fertility journey in the future. And some myeloproliferative disorders. Patients who have early ovarian failure predicted to them, such as Turner syndrome or Fragile X mutation carriers. And of course, patients of transgender care that are trying to change their gender from either male to female or vice versa, who would like to use their gametes in the future. Number of patients is increasing because cancer incidence, as you guys know the best, is very high right now. And American Cancer Society estimates around 700,000 women are newly diagnosed with cancer every year in the United States. And reproductive age cancer consists about 10% of those patients. And we're talking about reproductive age females. Breast cancer is the most common type of cancer that we see in our offices. It consists of about 80% of our patients. Then followed by hematologic cancers, brain tumors, colorectal cancers, and then other type of cancers and pediatric patients. So what do we do for survivorship care? If you look at these numbers, fertility among young breast cancer survivors, only 28% of patients who underwent fertility preservation after diagnosis are seen in our offices, and only 28% of them, which is like every third patient, would proceed with fertility preservation. Majority of the reasons are financial. That's why it's important to talk about their insurance and insurance coverage. And unfortunately, only private carriers are now covering that fertility preservation cycles with egg or embryo freezing for patients with cancer diagnosis, and not in all states of United States. Illinois is one of them, and we're lucky to be here. So if patient has private insurance and they would like to come in and have fertility preservation cycle, with private insurance, they will have coverage. It still will cost them some amount of money because it depends on deductible, on their co-insurance, medications are covered or not, and then storage, of course, is very important to discuss because storage will cost. First year is usually included in this IVF cycle, but after that, the patients will have to pay for storage. And we work with several companies who just do storage of eggs or embryos or sperm. And that is Reprotech, for example. They're huge and they have lower cost of storage. When patients are ready to come back, they can use those gametes later on, but they will be responsible for the storage cost, which is roughly between $300 to $500 per year. Then 73% of those patients became pregnant at least once after cancer treatment. And then 65% reported at least one live birth after cancer treatment. And that data is from one of the abstracts at ASCO annual meeting, which was just last year. So pregnancy after breast cancer treatment, because we see the majority of the patients are breast cancer patients, so the majority of our data is on breast cancer patients. So they are 60% less likely than women in general population to become pregnant. And different considerations are, again, here the stage of the diagnosis, when what type of therapy was done, what was the age at the time of diagnosis, what was the family planning type at the age of the diagnosis. And then survivors exhibited elevated risk of low birth weight, preterm delivery, and having a baby that was small for gestational age. Most of survivors who became pregnant, and that's a good point, had healthy babies with no adverse impact on long-term maternal survival. And that is, I feel, like an important point to discuss with the patients right before they come to be seen by us, when you guys are talking to them before sending them over to us, that we are happy to help, and then if they would like to, and there is time and cancer diagnosis allows us to do that, we will be happy to see them and provide care with fertility preservation. So if we look at the general numbers for male and female cancer survivors, 70% of female patients, cancer survivors, will have kids by the age of 45, and only 50% of male cancer survivors will have them by the age of 45. That difference is, I feel like, very interesting information. We don't know why is that, but I feel like women are pursuing fertility care and trying to get pregnant even after cancer treatment more than males. So this is new ASCO guidelines update on fertility preservation that was just published in March of 2025. So fresh off the press, as we say. And if you see in this busy table, but embryo cryopreservation has the highest clinical pregnancy rate. That's what CEPR means. And then live birth rate is quite high as well, which means how many babies are going to be born from frozen oocytes. But if you see the other line, miscarriage rates are still quite high, and the reasons could be very different. Again, it's all comers, all types of cancer survivors. They are not divided by the groups, it's just all the patients. And why that miscarriage rate is so high, it could be also due to the age, because we know with age and other pathology like fibroids, other uterine pathology, and recurrent pregnancy loss history, that could be increased for patient regardless of cancer treatment. Also chromosomal abnormalities, again, which are increased with age. So time requirement for embryo cryopreservation is about 2 to 3 weeks from initiation of ovarian stimulation, but we do need that time. And in order to freeze the embryos, if the patient is single, they need to be able to purchase donor sperm. If they have a partner and they're married, we can absolutely use husband's sperm, but again, those numbers have to be good. Husband will have to have some sperm available. I'm seeing some messages in the chat. I'm not sure if I'm supposed to answer them or something. David, you just let me know, okay?
Yeah, it's Betty Camp talking about the access to services and coverage of these services. She said that Medicaid covers in Illinois. And Betty, what exactly did
Yeah.
you mean by that comment?
Hold on, let me move things around. You had said private insurance covers in Illinois, which is
Yeah.
definitely true. And I just wanted to make sure that people understood that Medicaid, which tends to be labeled as public insurance, does cover as well.
At, at
I
this moment, we'll see what happens.
Yeah, I think it's still in the works, because I've seen a couple of patients recently, and Medicaid, I don't think they covered. But I think it also depends, because to my understanding there are different parts of Medicaid, different types of it.
Mhm.
So that's what it is. But unfortunately, for personal experience, I was not lucky to get coverage for Medicaid patients so far. I didn't have a lot in Illinois, but the ones that we had come in didn't have coverage, unfortunately. So
Do you
Yeah,
know Kristen Smith at Northwestern Oncofertility?
yes, not personally, but definitely no, yeah.
And if you need me to connect to her, she would be a good person for you to talk to. She might know some tips and tricks and the right words to use. And Debbie, to your point,
Yeah, they're looking
good
for
point.
cancer diagnosis and everything. Yes,
Yeah.
absolutely. But also time, I feel like is very essential.
Yeah.
Because if we have a little bit more time, as you know, Medicaid doesn't move very fast, unfortunately. But if there is a little bit more time, then maybe it's successful. And I would be more than happy to connect because I'm trying to help our patients as much as possible. All right.
Great. Yeah. Send an
Yeah.
email, Betty. Hook
Yeah.
you up.
Very good. Thank you. No, that's very good. Very important information. All right. So if we look at oocyte cryopreservation, the clinical pregnancy rate overall is 35%, very high live birth rate because 26 to 32%, it's actually really good numbers. In general population without cancer at some ages, you cannot reach that live birth rate, depending again on the age. But we need that time to be able to stimulate the ovaries, to get the eggs out, create the embryos, freeze them, and sometimes patients when they will test them. Ovarian transposition requires surgery. There is no treatment delay, but it's a surgical procedure when the ovaries are taken away from the place of radiation, depending on cancer type again and type of radiation plan that could be potentially done. Could be uncomfortable for patients because ovaries are taken away from their anatomical spots. Some patients do form adhesions and some discomfort and pelvic pain, but that's all minor and taken care of. And if patients undergo that and are successful, they're pretty happy. Uterine transposition, it's sort of newer kid on the block. It's when uterus is moved away for radiation in the pelvis and abdominal organs and basically taken out of the vessels and then reattached to the abdominal wall. So radiation could be used lower and uterus is kind of sitting on the abdominal wall waiting for its time to be getting pregnant. It's pretty new. There are some successful pregnancies reported in literature, but that still is investigational method. So hormonal suppression with GnRH agonist is probably one of the most common modalities that we use, especially for patients who don't have time or don't want to wait until they have stimulated ovaries and frozen eggs. That could be given pretty much to any patient, and leuprolide is the most common medication that is given. It does have protective effect on ovarian function, and relative risk for maintaining ovarian function is 1.6, which I think is pretty good. It could be stopped once the treatment, cancer treatment is over, as you know, and then ovarian function resumes depending on type of cancer treatment, doses used, and type of chemotherapy agents that were used. Ovarian Ovarian tissue cryopreservation also is a good method. There is no delay. We don't need time, just the surgery. It's a good method when patient is going to undergo already, could be if the surgery is not planned. For some patients, that an extra risk and extra time and extra cost, and they don't choose that method just because of the surgical risks. This is a good method for prepubertal girls or young kids to have ovarian tissue cryopreserved, but again, depending on type of cancer, what we don't want to have in the future is reintroducing cancer cells into the patient's body when we have to use that tissue back and stimulate that. In vitro maturation is another method, and there are some births reported from that, and that is a shorter stimulation, if any, depending on the type of a patient again, but ovarian egg retrieval under anesthesia, and then maturation of eggs in petri dish in media for the future use because they are taken out very early and very early stages of their development when they're not mature, and they have to continue and complete maturation throughout the cycle of oocyte life to become mature, to be frozen. and that takes some time and special techniques, and not a lot of labs in the country are doing that. So gonadotoxic chemotherapy has a lot of impacts on ovaries. It destroys ovarian follicles and accelerates ovarian aging. Timing is critical, and if it's prior to puberty, it could lead to pubertal failure. During early to mid reproductive years, it could be primary ovarian insufficiency, which is defined as menopause or loss of menstrual function before the age of 40. After 40, it's considered early but menopause. Before 40, it's premature ovarian insufficiency. And if it's in late reproductive years, it could just cause early menopause. So how does chemotherapy impact the ovaries? It's damage depends on the type of chemotherapy and the age, as we already mentioned. And average rates of chemotherapy-related amenorrhea on cyclophosphamide, methotrexate, fluorouracil chemotherapy are about 40% if patients are younger than 40 years of age, and 76%, which is a lot, in patients who are older than 40 years of age. Complete ovarian failure and permanent infertility resulting from chemo occurs more often in older patients. We see that with age as well, because ovary is already aging and we're given extra hit with chemotherapy. So that's why ovary does not survive well. So what do we do as initial considerations as REI physicians? We discussed available methods, and it's again age dependent. We always discuss alternatives because we can defer fertility preservation and assess ovarian function in the future after treatment, because it really depends on what type of cancer patient has and what type of chemotherapy or radiation is planned for that patient. They can always use in the future donor gametes or embryos, or we also talk about adoption. The biggest difference from these patients to the patients who present to our offices with infertility is that the patients with cancer do not have infertility. So if cancer type is gonna have chemotherapy that is not very gonadotoxic, we always tell them that you can come back later. We can assess your ovarian reserve right now. You can come back later and see what is your ovarian reserve, and you might not need our services. Even if you freeze the eggs now, some patients are able to get pregnant on their own. For example, early breast cancer patients who have only surgical treatment and no chemotherapy or radiation. But they still get scared about cancer diagnosis, and they still would like to come and talk to us, which is really great to have because that helps everybody in the long run. We also consider patients' current health status and stability for the procedure. Everybody undergoes anesthesia consult because, first of all, it has to be safe for the patient. We always talk about future need for gestational carrier. If patient is going to have surgery for uterine removal or pelvic organs removal, they might consider gestational carrier. And here again, expense is very high because to have gestational carrier and carry pregnancy for them, roughly the cost starts from $100,000, and a lot of patients cannot afford that. So for them to create embryos or freeze eggs, knowing that they are going to have hysterectomy, they need to know what cost is associated with that in the future. And some of them refuse to do that because they're not going to be able to, unfortunately, have that available to them later on in life. We try to convince them to do it because if they have frozen embryos and they have sister or non-gestational carrier, like a friend who can do it for much less or no money at all, then patient and their family can benefit from it in the future. So we discussed that, but again, patient makes the final decision. And we absolutely need to talk about disposition of gametes and embryos in the event of patient's death. That's why we have to sign multiple consents for that. So that is a brief pre-treatment REI counseling. When we say if we have time, they start folic acid supplementation or prenatal vitamins. And in general, when you guys are seeing patients in their reproductive years, it's good to suggest them to be on folic acid or prenatal vitamins, because it's either they're trying to get pregnant or they're breastfeeding their children. It's a lot of years or out of female's life when they actually will benefit from prenatal vitamins or folic acid. And it's very easy to take. It doesn't have side effects, but the neural tube defects prevention and decreased risk of that is quite significant. We do review the medications, but again, we talk with oncology team a lot, because we cannot stop or change any of the medications that you guys are planning for those patients, and we need to know what they are and how gonadotoxic they are if patients already have started anything. We absolutely have to check for sexually transmitted diseases by FDA requirements because of the storage and future use. And that is HIV, hepatitis B and C, syphilis, and gonorrhea and chlamydia. So we do very quick targeted workup, and if we have very limited time, it's just the ultrasound to count the follicles to see what part of the cycle the patient is. And if I have time, I can send only anti-Mullerian hormone to know patient's ovarian reserve, so I start them on a right dose for the stimulation cycle. Because that could be one time for the patient during their life that they will do it. After that, they might not have available eggs or sperm. They, in this case, we're talking about female patients. The eggs, anti-Mullerian hormone is going to tell us their ovarian reserve and will help our EI doctor to choose the dose. And doing it right just once, it's the very important thing for everybody, because patient will be using those gametes in the future. They might be the only ones. And if they are married or have a partner, they can create embryos, and or they can use donor sperm. Because remember, in the data from guidelines for fertility preservation, the best outcomes were for the embryos still. Embryos. We do talk a lot about consent forms and we sign them. They must be signed prior to any procedure or treatment cycle start. They are very extensive, and there is a good reason why. There are a lot of possible risks and complications, like hyperstimulation syndrome, which is pretty rare right now, but we still need to talk about it. We do not want patients to get it and have a delay in their chemotherapy or surgical or radiation treatment in the future. It has to be signed by both partners or parents in case of pediatric patients. And then we need to define also ownership of gametes or embryos for future use. Ideally, it's good to have Oncofertility team and patient navigator. I cannot say enough how important are those people. And we work with oncologists, reproductive endocrinologists as us, and non-social worker, anesthesiologist, psychologist, nursing team, our embryology team. So everybody gets on board so we can have a successful cycle for that patient. Usually it takes about 10 to 14 days of medications, and it's self-administered. There are about 5 to 7 visits for blood work and ultrasound. Then ovulation is triggered 36 hours prior to the retrieval. Retrieval is under anesthesia. And then if eggs are frozen, they will be thawed and injected with the sperm in the future. If patient choose to do embryos, embryos are created. But the next day, patient is free from all of our treatments. We do discuss treatment with or administration of medication, such medication as Lupron or GnRH agonist, and they can receive it the day of the retrieval or the next day, and ovaries are shutting down at that point, and they are good to proceed with your care for future cancer treatments after that. If we do have time and patients would like to do another cycle, we can quickly re-rotate them and start another cycle right away. This is just IVF cycle, rough representation of that. And we do offer genetic carrier screening for the embryos if patients are trying to create the embryos, and most of the patients choose to do it as a PGTA test or pre-implantation genetic testing for aneuploidy. Because if they are over 35 and they want to know the chromosomes of their frozen embryos, they would also know the gender, and it gives them a good idea for the future how many children they can plan or consider having, if they would like to know, of course. It's not covered by insurance. Majority of insurances do not cover PGTA. It's an extra cost for the couple, between $2,000 to $3,000, depending on the number of embryos they would like to create and test. Okay, we do use vitrification in all our labs, and that is very quick freezing of the eggs or embryos when they're desiccated, so the water doesn't form crystals and doesn't break egg or embryo. So American Society for Clinical Oncology guidelines do emphasize that healthcare providers caring for adult and pediatric patients with cancer should address the possibility of infertility in the future and as early as possible before treatment starts. And then it's always, or most of the time, it's possible to do, but again, there are different steps on the way, different barriers to care, like cost or time or health of the patient, or even emotional support is extremely, extremely important, because cancer diagnosis is very stressful and patients are very concerned about their health and their future at that point. Some of them cannot even think straight about future fertility, but we do need to have that discussion so later on they can come back and have their family. So we try to see patients within 24 to 48 hours after the referral. We do have some slots in the schedule, and if we have to see them over time, that's not a problem. We do consults in the hospital if patients are admitted, and we always see them as soon as they're ready to talk to us. There is a huge psychological impact, even if they don't pursue fertility preservation treatment. Just talking to REI specialist and discussing the options and choosing, for example, GnRH agonist as Lupron does help them in the long run. And you know this better than I do, that gonatotoxicity of agents is extremely different. But for us as REIs, alkyliding agents in combination with radiation are the most gonadotoxic. So we already discussed those fertility preservation methods, and patients can present to us in different timing of their menstrual cycle. Some of them could be on birth control pills, and that's the easiest way to start them into fertility preservation cycle, but they could be in the beginning, middle, or luteal phase of the cycle, but it does not matter. If they're nearby the ovulation, we can always trigger their ovulation and then start the stimulation of the ovaries, because ovaries are very forgiving and nice organs. As soon as they see some follicle stimulating hormone, most of them try to respond and work pretty well. So we do start them random versus conventional follicular start, and there is no difference in number of oocytes retrieved, mature eggs retrieved, or fertilization rates. But the benefit is time, which means when they come, as soon as they get approval of insurance and medications, they are able to start. The cost, as we already spoke about it, it's quite expensive. If it's not covered by insurance, it starts about $5,500 for the cycle, depending on clinic and the area of Chicago that is done. Medications could be extra $2,000 to $6,000. Anesthesia for egg retrieval about $1,000 if not covered by insurance. Then storage depends on where it is, between $300 to $900 per year. And then coming back for egg warming or thawing, fertilization, and embryo transfer is about $5,500 again. So 5 years of storage and one transfer out of pocket without insurance could be between $15,000 to $18,000 for patients. So cryopreserved or fresh oocytes do not have any difference in fertilization, rate of top quality embryos, implantation, or ongoing pregnancy or live birth rate. That's why it's so widely used and became from investigational into approved by FDA and American Society of Reproductive Medicine a while, and we're happy about it, and we can offer this for our patients. Very common question we get is how many mature eggs do I need to freeze? Because only mature eggs are going to be frozen. That is mostly for patients who have time. If they have time and they can wait and have a couple of cycles, then we can answer that question and say, okay, according to your age, we'll give you the number, how many eggs we'd like you to freeze. But for the patients who don't have time and need to start chemotherapy right away, they have one-time cycle. So as many as we can safely get for them, that's the answer for those patients. But the estimated pregnancy rate for patients less than 30 years of age is about 7.5% per oocyte. And as age increases, unfortunately, efficiency decreases. So we suggest to freeze about 15 to 20 eggs for women under 38 years of age, which is giving them about 70 to 80% chance of at least one live birth, or 25 to 30 for women between ages of 38 to 40, and that is about 65 to 75% chance of at least one live birth. But majority of the data that we have over the years is from infertility patients. Cancer patients, we're only now getting some good data when they start coming back for throwing those eggs and using those embryos now. So there is not too much data available, but there is some that's coming, which is actually very rewarding and very interesting. So there is no increased risk of congenital anomalies, chromosomal anomalies, or low birth weight. That's again a very common question, if it's safe or not to have it frozen, embryos frozen and used in the future. And when to come back. We tell patients anytime when you're ready to have a baby, and first and most important, when you're cleared by your oncology team for pregnancy. It's at least 6 months after last chemotherapy. That's advisable time for them to come back. But patients come back at different time frames in their life. 6 months, they might not be ready yet, or they are not ready even in a couple of years. Some of them don't ever come back, but it gives them some peace of mind that they have frozen eggs or even embryos created for them, waiting for them for the future. Oncofertility Consortium is a wonderful organization. It's a multidisciplinary committee. It has very nice goals that they're continuing and improving treatment protocols for us, discussing patients' ethic questions and issues and concerns that literally come up on daily or weekly basis, and they do have amazing clinical research going on. A good resource for the patient is myoncofertility.org. If you ever have to refer them, I'm sure you know about all of that, and I'm happy to answer any questions that you guys have.
Oh, thank you, Dr. Snegovskikh. I still have
You got
Snegovskikh, for
That's
this
okay.
wonderful talk. It's such an important topic for so many of our cancer survivors, as cancer is trending younger, right, as we know. I find that radical about the uterine transposition that they're doing that. How often do you see that like a uterine or an ovarian transposition is helpful in retaining the an ovarian?
It's still investigational method, like ovarian tissue cryopreservation used to be investigational for a while, still in some places is approved and others don't, and I'm talking about the world. So uterine transposition is not very commonly used. It's a pretty difficult technical surgery that needs to be done, and it's still investigational. So personally, I haven't seen any patients before or after that. I only know it from the literature, but there are case reports and there is information about it. but I have not done or seen it done in real life yet. But it's definitely promising if patients need pelvic radiation or abdominal radiation. Uterus is attached to the abdominal wall, so it's saved away from that area, which I think it's promising, but it definitely is some technical issues, and for pregnancy could be challenging in the future because cervical insufficiency is reported when cervix just doesn't hold pregnancy in the future. So there are some issues. They need to have cerclage, which is a stitch that will hold the baby in place and keep the cervix closed. So some of those things to consider. Definitely always new things are interesting, and we always try to stay on top of new research that's coming. That's very good options
Yeah.
for
That's
patients.
wild. I guess my question was also for ovarian transposition, how often do you see that actually working? Because I see patients that have decrease in their hormonal function, even if they have the transposition of the ovaries to avoid the radiation field.
It's not the most successful method, especially if patient didn't have time to freeze eggs or embryos, but definitely better than nothing. Let's put it this way. It's better to try to take the ovaries away from radiation field and see what happens rather than leaving them where they are and they're right in the middle of that field, especially for like cervical cancer or uterine cancer when they need to have radiation, ovaries are like right there. If they're a little bit away, also blood supply suffers to the ovaries at that during the transposition. As least as possible, the surgeries are done very carefully, but still ovaries are sitting behind the uterus in a normal physiological pelvis. But if they are attached again to the pelvic side walls and sort of stretched and under tension, that decreases their blood supply, and that's why some patients get not the best outcomes from that. But also, cancer itself, I feel like, has impact on bodies even without chemotherapy or radiation. Cancer patients do have slightly lower ovarian reserve, and as I mentioned before, lymphoma patients, for example, prior to any treatments, they have lower ovarian reserve. It's probably the lymphoma itself that affects the ovarian reserve, and they don't stimulate well. Even young girls, when they come with lymphoma, that's my personal experience during the years doing this, that they just have this issue.
Yeah, I think you're so right. I see that all the time. I'm like, why would this happen? But it has to be just the cancer. I always tell patients I don't put anything past cancer. I'm sure we have questions from the audience. Betty, Michelle, do you have some comments? I saw you come off camera.
Oh, yeah. Hi, I'm Michelle Kirshner. I'm the Director of Program Development for the Cancer Survivorship and Supportive Care Professionals Network. And we bring everyone together, multidisciplinary care. And Deborah, thank you for posting this. And I see Betty. And I see Joshua. I see also a bunch of people. Anyways, what I wanted to say, and I love what this idea of how cancer changes the person in general. And so I really want to be expansive about when we're, how can we support an individual as they're going through these processes in a very multi-dimensional way, looking at nutrition, exercise, movement. And actually, I'm involved with a platform that does coaching, and we have perinatal coaching that is, pre and post, and so I've seen that model is working really well, and I'm wondering, have we mapped out what is like comprehensive supportive care around these processes?
It's a very good question. And again, that requires a nice team that will work together. One doctor or one patient cannot do that.
Right.
We need support from, navigators, nurses, social workers, psychologists, all together. And I don't think at UIC we really have yet that team for it, and I'm talking for fertility preservation for just like fertility patients. We definitely have the team that can take care of patients and help them freeze their eggs and create embryos. But further on, when they come back, it would be nice to have collaboration also with you guys, that when patients are ready to come back, they really need way more than I feel like as just a single doctor you can provide to them.
Well, we would love to partner with you on creating that because
Yeah.
we have all the disciplines. But I wanted to mention also one of the things that we talk about a lot is looking at how cancer centers function, that we probably won't be able to have all the services internally within a program because you're like you're saying. So what we're really talking about is we're looking nationally at resources that we can partner so we can tell our patients, here's a program that can be supportive of you. So I highly recommend coming together around this work because if you look at the patient experience, and I'm talking because my daughter-in-law is as a cancer survivor, she had a loss, she's had cerclage, she's had fertility treatment, and so I lived that experience with her, so I know very clearly what it's about. And I feel like we don't see the experience from the individual side, and we're not providing, we're kind of, again, giving the medical treatment, but we're not giving the full support. So I would love, again, to come together with you and
Sure.
your teams. And Deborah is a great, is a wonderful.
Oh, absolutely. Yes, thank you very much. We definitely need more for these patients, like support groups. A lot of patients ask about support groups. They all now go to, Facebook, TikTok, and all that. But coming in and sitting next to another cancer survivor and talking about experience and go what they have been through and sharing this real life events or real life circumstances that they have been through, I think it's very important for these patients. And if we can organize something like that, that would be extremely, extremely helpful.
Good. Well,
Great.
let's
I know
Thank you.
Betty's in.
Yeah.
Betty.
Yeah, and Michelle, of course, you said a couple things, that whole mapping out, right? And then the whole support group. I know an AYA who heads up an AYA org who has had some fertility post-diagnosis concerns. And so I'm like gonna reach out to her because I think having a support group. And Michelle, to your point, individual sites can't do this.
Yeah.
Nationally available is what we need for this population. So many great things. Your talk was great. I can't wait to go back and see the recording. Deborah, don't worry about that interruption. Somebody can put those two pieces together. And if they can't, I can do that for you. You gave so many little bits of information that's new to me, your statistics. Thank you for all of that. I I love the idea of a surrogate that might be a relative or a friend. I've never thought of that before to reduce that huge $100,000 cost. Thank you for that suggestion. That's brilliant. And I just wanted to say, I work in the AYA space and I work with sites across the country. Fertility preservation, still 50% of AYAs are reporting not having any conversation. And that's sad. Many, many, many can't afford it, of course, but they all deserve the conversation prior to treatment starting. Because to learn that your fertility was affected after only adds to the PTSD that cancer brings a young adult. So I encourage anybody on this call who actually is with patients at diagnosis, please, 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 if you don't know how to have the conversation, find somebody who does. There are many different organizations that have Oncofertility offering webinars and learning opportunities to how to have these discussions. So it is just imperative that they understand. The other thing that we talk about, we have quite a few sites who will give this conversation to every person who is of fertility age, even if they aren't having surgical removal of organs or interruption or radiation or chemotherapy, because the psychological aspects of cancer recurrence rates and second cancers can also affect fertility.
Absolutely.
But Betty,
And
can I want to mention about the conversation because I think something that's very important is that we actually need to track and document that that conversation has happened. And that is it if and so that comes back to developing EMR systems that can do that. So at the University of Cincinnati, when I was the director of our supportive care, I actually worked with our Oncofertility to create a trigger that was a reminder. So we again looked at the risk factors that identify patients that must have this conversation. We started kind of with the highest level, and then and obviously women within a certain age range, and having certain treatments, and then we created an actual trigger that would come up each time until they actually filled out the form. So really best practice around documentation is probably another thing that we really need to make sure we talk about nationally.
Right.
Yeah, and another thing that comes to mind from my training, my personal experience as a BRCA carrier, how many patients do you see that are previvors? Because we work with a lot of cancer high risk patients as well. And do you see them also in the REI clinic?
The patients that are carriers of the genes, or
Yeah, or carriers of BRCA mutations or other
yeah.
mutations that would put their fertility at risk because they need to consider a early risk reducing BSO.
Yeah, so they do come. It's not very often, but I think it's getting more and more once the information is out there. Some simple thing is that patients don't know. And when they have that diagnosis or they are informed that they're BRCA carriers and they're offered the, removal of the uterus and the ovaries, some of them don't think about the future, and some of them are not ready to have a child at that point. And there are patients who come back, unfortunately, after that. But we do see with the now extended genetic carrier screening, we do see more and more patients are diagnosed with BRCA carrier. And if they come to us and they're ready, we're absolutely happy to see them. We do the counseling, we go through all the, possible thoughts that could be done, and we definitely work together. The PGTM that I have mentioned, the testing for aneuploidy is one thing, is for chromosomes, but PGTM is for genetic conditions, monosomal gene disorders, and we do work with reproductive genetic innovations. For example, that's the company here in Chicago that can have a genetic counseling with the patient and see if that embryos could be tested potentially for that gene and could be eliminated for the future for sure. So this is definitely happening.
Yeah, I put a link in the chat. We were talking about the Magnolia Tree Foundation. It was Alexa Rodheim. My acupuncturist was Hannah Rodheim.
Yeah.
And she talked to me about the services that they offer, grants for BRCA carriers or yeah, BRCA1 and 2 mutation carriers, and they have grants for things like PGT, BGT, and embryo preservation for that
Yeah,
population.
good. Because it's also very expensive. Creation of the probes
Right.
itself starts from $5,000, and an IVF cycle itself, and all the costs that I already have mentioned still apply. Yeah.
Yeah. So financial support is a top.
Extremely important.
Yeah.
Extremely important.
Betty, do you have some resources?
yeah, I do have a ton of resources. I was trying to find where I could copy and paste. I'll try to do that in the next few minutes, but I just wanted to also say on the flip side of all of this, especially with young people, if you are a provider who are seeing patients post primary care, remind them if their ovaries and testicles were not removed, there is still, even if they were told that they had gonadotoxic treatment, they still could get pregnant. There
Oh,
is still,
absolutely.
right? And so make sure that they are aware of that, because I have heard of clinicians who see a patient in survivorship, they come in pregnant, or they say, oh my gosh, my partner got pregnant. We didn't know we could.
Yeah, no, no, we always talk about it. We always talk about it. Even if they have very, very low anti-Mullerian hormone, there is still, and they're young, there is still ovarian reserve. I always tell them can get pregnant, so think about it for the future. If you're not ready or health-wise you can't get pregnant at this moment, please, please consider birth control. Yes, absolutely. Very important. Yes, we talk about it.
Such an interesting topic, and we can go on all day, I'm sure. Betty, yeah, put those resources in the chat. I will send out the chat, and if you could send me your slides.
Yeah,
Or
absolutely.
something.
Works the Way charity is really good, actually. I've referred
Oh
patients
yeah,
to it. Yes. I see that Betty is sending it now. Yeah, Works the Wait is really nice. Yeah.
I
Yeah, and
actually, yeah, I actually found I asked you actually, Victoria, about that patient who was searching for surrogacy because unfortunately, like surrogacy is not covered at U of I. And so I reached out to her though with numerous resources, and I actually got a really nice list from Gemini
Mhm.
on the internet. So I offered, and one of them was worth the wait. And
Yes. Yes.
yeah.
and the SAM fund will even cover adoption fees. They cover a broader range of
Mhm.
financial concerns. So
Yeah, there's so many resources in this area. We need a good comprehensive list for all our AYAs who are considering this and worried about this.
I wonder if we can have, like, Betty, since you're such a great resource for all of this, I wonder if we can have like a little pamphlet or like a printout, like almost like a, bookmark for the patients that we can give out in the clinic, or like an epic. We all use epic, like an epic phrase or dot phrase or post, visit summary that we can create. Maybe it's I was thinking about talking to epic people to see
Mhm.
if we can create like the list that we would like to give the patient so they can go back home and open my chart and see the resources and be able to click it and be able to use them. Maybe that's very, very nice. If we can maybe put together through the email at least, and then work, and I will try to work with Epic team to see if we can have like post-visit summary or something for those patients, because they're stressed. They're very, very, very uncomfortable. They have a lot of things going on, multiple appointments, MRIs, PET scans, you name it, right? You know better than I do.
right.
And to add our treatments on the top of that, and psychological things and emotional things, it's unbelievable how they even do this. So whatever support we can provide, that would be absolutely amazing.
Yeah, in life. I mean,
Yeah.
because the adolescents and young adults, I just spoke to a 23-year-old with sarcoma yesterday,
Oh, no.
and it's, there's jobs, there's apartments, there's living situation, education. It's life still happens.
Yeah.
So,
Sonia has sent us a nice wellness house available for free psychological care, psychosocial. Wow, groups or one.
yeah, I
Okay.
refer many of our patients to Wellness House, and we send that information. Um, and they're a great resource for psychosocial support and are working on training others in Illinois to give the same psychosocial support to branch those services out across the state.
Wonderful. Okay.
Yeah.
Thank you so much. That's great to know the resources, the people, the
Yeah.
team that are.
We could send you a long list more. Dr. Ganshow, did you have something to say? Did you come off mute
I
for?
did. Thank you, Debbie. Sorry, my computer's not working, so on my phone, so I'm not on camera. But I just want to thank you, Victoria, for an excellent presentation. And I think our team, we could have some members of our team help you with some of those patient education information, and maybe even add it into Epic as a patient education document that we could just, add into the after visit summary. I do think I just came across this when I was in clinic last week. I had a patient who wanted to pursue this, and she only spoke Spanish. So as we put some of this information together, I think also understanding the organizations that actually support Spanish speaking, and we had Kristen look into this, and she did find, I think it was worth a wait, had
Yes.
people that also were bilingual and could help some of those patients through that initial process on that outreach. So happy to work with you. And this was just a fabulous conversation. And thank you, Eddie and Michelle, for
Thank you very much,
input as well.
Thank you. We're happy to collaborate, whatever we can do to help our patients and teams. Absolutely.
Oh, yeah. And Tamara reminded us, Yas, the internal at UA Cancer Center and the Center for Equity, and remind me, Tamara, CEC. Yas has a pocket resource guides in Spanish and English for cancer survivors. And Tamara, I think those includes some information about this, right?
Yes, so they're targeted specifically to the needs of young breast cancer survivors under 45. And there's fertility information both for at the time of diagnosis and then across the cancer care continuum. So we have stuff for women who've completed treatment and women with metastatic disease as well. So I'm happy to share those. They're about the size of your cell phone, and they're accordion style, and we pass them out in the clinics. And I have no idea who they go to because we never get any feedback on them, but I'm happy to share them with anybody that is interested in sharing them with patients. I can deliver them.
Yeah, I think we need more in the clinic. We put them in our new patient packets, Keisha does, so they're really helpful. So I think we may be due for a restock. Thank you for the reminder.
Okay.
Good.
Yeah,
Wonderful.
we could definitely, you were so right, pool together all these resources for our patients into, an epic document, a smart phrase, even trying to put it somewhere on the Cancer Center website or something, the REI website.
Yeah, that'd be great.
So we have different places and multiple places that patients can find these resources.
The more the better, because they're stressed. They don't know where to look. And if we have good resource stock for them, that would be so nice. Yeah.
Yes. So Betty, send some emails. We will start collating all this because it's a very important topic for patients, for AYA especially. I mean, not just AYA, anyone of reproductive age. So
Thank you guys so much. Thank you for having me.
Yeah, thank you so much, Dr. Snegovskikh. Thanks everyone for coming. Some participants have left to other meetings. This was a fantastic talk, and I will get the recording up as soon as possible. Have a great day, everybody.
Bye. Thank you.